next I call upon Dr. NEENA R, Head of the Department of Pediatric Ophthalmology and Strabismus in Giridhar Eye Institute, to cover an important topic of traumatic optic neuropathy in children, when to suspect and how to manage.
Thank you, Lakshmi and KSOS for this opportunity. So I'm going to talk about traumatic optic neuropathy in children, when to suspect and how to manage. So we know that traumatic optic neuropathy is an acute injury of the optic nerve secondary to trauma. And just like in adults, TON in children is an important cause for poor vision and has poor has poor visual prognosis if you don't pick it up early and intervene. Because even if you intervene, some of them does seem to have very bad prognosis. So the signs would be the same as in adults. But children being less expressive, they don't often complain about defective vision and they won't be very expressive in their complaints. So we need to have a high index of suspicion to diagnose TON in children. So just like in adults, there would be vision loss, color vision loss, visual field defects. RAPD is an important sign in cases of trauma. Often we miss the pupils, and that may be the only sign which would be the definitive indicator of an optic nerve injury. And sometimes there would be orbital signs like fracture, resistance to retropulsion, retrobulbar hemorrhage, and proptosis may be there. So we can classify TON as direct and indirect TON. Direct TON is due to an anatomical disruption of the optic nerve, either due to a direct penetrating injury to the optic nerve or due to a compartment syndrome from an orbital hemorrhage or an optic nerve sheath hematoma. Indirect TON is due to a shearing injury to the intracanalicular portion of the optic nerve, either causing an axonal injury or an ischemia of the optic nerve. So causes can be multifactorial. So as early as Hippocrates, he was one of the first people to describe that traumatic optic neuropathy could be a complication of head injury, and blows to eyebrow may cause blindness, and this is called the Hippocrates sign. So if you have any patient who's walking into your OPD or who's brought with a scar which is involving the medial 2/3 and the lateral 1/3 of the eyebrow, there is a very high chance that the child or the person may be having a traumatic optic neuropathy. And the site of injury is usually the forehead or supraorbital ridge, and less commonly the temporal region. So this is an important, the blows to the eyebrow is an important cause of traumatic optic neuropathy. Now, there is an anatomical classification given in Walchenhoid's neuroophthalmology. I thought I'll just put in for the sake of information. You can have depending on where the trauma to the optic nerve is. If it is to the nerve, it's visible to us as optic nerve avulsion or a hemorrhage to the optic nerve. If it is in the proximal portion of the optic nerve within 10 millimeter of the globe, it presents like an anterior traumatic optic neuropathy. It can present with either a CRVO or a CRAO-like picture, or an anterior ischemic optic neuropathy like fundus picture. But if the injury is posterior to the entrance of the vessels, it presents as a posterior traumatic optic neuropathy with absolutely normal fundus, and you may pick up the pallor only after 4 to 6 weeks of onset of trauma. So these are some of the pictures. You can see the avulsion here in the first picture and a CRVO-like picture. So sometimes if you have a high index of suspicion, and you can do a flash VEP, and they say that flash VEP amplitudes less than 50% of the normal are a prognostic, like they say that it's not likely to improve. So CT orbits is a very good tool to evaluate the orbit and the optic canal. So especially if you're suspecting a direct traumatic optic neuropathy, look for optic canal sections and look for any fractures or any crowding of the optic canal, and both look for the sagittal and the axial sections. So if you have a direct TON and with a compressive element, definitely there is an indication for decompression. Discuss with the neurosurgeons and do as required. So these are some radiographic pictures which I picked up from the American Journal of Neuroradiology. Beautifully, they're showing the complex facial fractures here with the fracture in the bone segments in the optic canal of the right side. And in this picture, you can see there is a medial orbital wall fracture, and if you see the optic nerve is stretched. Normally, the optic nerve is tortuous when you have it. See, this optic nerve is stretched, so that indicates there is trauma to the optic nerve. And in this picture, there is a fracture of the posterior orbital lateral wall, and you can see that the left canal is normal, but you can see there is a widening of the canal here. Soft tissue injuries can also produce traumatic optic neuropathy. Like here you have this hematoma, which is abutting the left optic nerve, and here there is bilateral injury, and you can see that Here there is avulsion. The left is totally disorganized globe, but the right globe is also, there is avulsion, and the optic nerve and the optic nerve head are thickened. And here is another picture showing the optic nerve sheath hematoma. So these pictures can be visible. So these are some other pictures that will tell you axonal injuries can be picked up on MRI. So I've already described this. So there is controversy regarding management of the optic nerve, traumatic optic neuropathy. But what we generally do is, if there is a direct traumatic optic neuropathy with a hematoma or a bone fracture impinging on it, you have to go and do a surgical intervention. Systemic corticosteroids is controversial, but we do give IV methylprednisolone if there is no traumatic brain injury. You have to discuss it with the neurosurgeon. There are conflicting reports. This case series, the prognosis was not very encouraging, whereas they found that surgical intervention in pediatric population did help to improve their vision in as much as 80 of their case series patients. So just a few cases. This is a case of optic nerve head avulsion. You can see the OCT and the B scan picks up these. And this was an injury with a bat, vitreous hemorrhage, and Berlin's edema was there. Vision was very bad, but there was RAPD, and VEP showed a prolonged latency, and we treated it with IVMP, and vision improved, though not much. Another patient who presented late, pale disc, history of fall 5 months back. Can't do much now because already the time is lost. So it's difficult to diagnose, high index of clinical suspicion. Give them the benefit of doubt, intervene when early, and prognosis usually is guarded if you don't suspect it early. Thank you very much.
Thank you, Dr. NEENA, for that extensive coverage. So